Hi, everyone. Welcome. Give everyone a minute as they join. I know a lot of people here hop from one meeting or one appointment to another, so we'll go ahead and get started in just a minute. Great. You'll see a poll pop up there just so we can kind of gauge our audience. Thank you, everyone. As you come in, welcome everyone to Adolescent Sexual Health Care during the COVID-19 pandemic. Why use telemedicine in a post-pandemic world? I'm Catherine Cushing. I am the Senior Program Manager for Quality, Research, and Evaluation at the School-Based Health Alliance, and I am joined today by my wonderful colleagues, Jerica Davis, who is the Senior Manager of Adolescent Health at the National Coalition of STD Directors, and Dr. Jennifer Salerno, who is the founder and CEO of Possibilities for Change. Thank you everyone for joining us today for our webinar. Oh, and we are split exactly 50-50 right now on who is using telehealth for our currently. Wonderful. Okay. As a reminder, all attendees are in listen-only mode. To ask a question during the session, please use the Q&A icon that appears on the bottom of your Zoom control. If you want to chat something that isn't a question, please make sure that you're selecting that as going to all panelists and attendees before typing your message so we can be sure that everyone sees your comment. And please make sure that you are completing evaluation poll questions at the end of the presentation. Thank you in advance for your participation here. Our objectives for this webinar are that we are going to focus on how the COVID-19 pandemic has affected the delivery of adolescent sexual health services, the continued use of telemedicine in providing adolescent sexual health services, including hybrid models of care, and strategies to ensure that health equity when providing adolescent sexual health services. And with that, I will pass it off to Jerica to introduce our first speaker.
Thank you. I'd like to introduce our very first presenter for today, Dr. Sarah Wood. Sarah Wood is a physician scientist with a career mission to improve quality and equitable delivery of sexual and reproductive health care through developing and implementing innovative healthcare delivery strategies for adolescents and young adults. A former community health worker and HIV tester, Dr. Wood is an assistant professor of pediatrics at the University of Pennsylvania Perelman School of Medicine, an attending physician, assistant director of adolescent HIV services, and a faculty member in policy lab at the Children's Hospital of Philadelphia, CHOP, and the co-director of the Penn Center for AIDS Research Clinical Core. Dr. Wood provides medical care to youth living with and at risk of HIV at the CHOP Adolescent Initiative Clinic. Her NIMH-funded research focuses on developing and implementing an HIV prevention intervention in adolescent primary care for youth with STIs. Dr. Wood, the floor is yours.
Thank you so much for the introduction, and I'm so happy to be here today. I titled my talk, "The Bad, the Good, and the Better," when talking about delivering sexual health services during COVID, because while we're going to focus on how we have a long way to go to rebuild and actually make gains beyond where we started, we've also had a little bit of a couple years of innovation lab that I think has in many ways left some of our health system better than where it was when we started. Next slide. So I have no conflicts of interest to disclose. I am coming from this, putting myself in the context of someone who works within a large pediatric health system. We have 31 primary care clinics and 4 adolescent specialty health centers. And I'll be talking about a lot of innovations in care today within our sort of own clinical model. I'll be talking about emerging STI testing technology, and I'm funded through the NIH. Next slide. My learning objectives are pretty straightforward. I'm going to be talking about challenges and improvements in the scope of STI care delivery before the pandemic, during the pandemic, and the changes and innovations that have emerged after the pandemic. Next slide. Keep on going. So as most of the people on this call may know, we've really faced unprecedented rates of STIs in the United States. And this is coming into the pandemic. This is our last year of sort of reliable data from 2019, where we had the 6th consecutive year of increasing rates of STI cases, leading to the highest all-cause STI rate we've ever had. And you can click. We also know that there were significant disparities in these STI infections. We see higher rates of STIs in Black, Indigenous, Latinx, and other people of color. And I want to really emphasize here is that this is not for biologic reasons. This is due to both implicit biases in who gets tested for STIs and the impact of structural racism and segregation on disease transmission. Important to also note in a lecture about adolescents that over 50% of these STIs are occurring in adolescents and young adults. Next slide. So I'll talk a little bit about our clinic and what our clinical system and what we looked like before the pandemic. And I'll say we are one of the best clinical systems in the world, but we had substantial shortfalls when it came to chlamydia screening. So we actually looked at our data from 2015 to 2019 to say, of teenage female sex at birth individuals coming into clinic, who's getting screened for chlamydia? So we had 38,000 teens coming in for almost 70,000 well visit, and we found that only 12%, a little less than 12%, were screened annually for chlamydia. Now, we had clinics that were really high screeners amongst our 31, and we had clinics that were screening no one. So when we averaged that out, only about 5% screening rate across our clinics. And it wasn't because chlamydia is not an issue. Almost 13% of our tests were positive. Next slide. And we also knew that there was an equity issue here. So when we looked and saw who was getting screened, we again saw only about 11%. That's 6,000 people in the bottom circle. And then we looked at how does patient race affect who's getting screened. So 66% of the Black patients were screened, while 24% of white patients were screened. And we thought maybe this is due to clinical factors or geography, but when we looked down to the level of the individual provider, adjusting for patient factors, clinic factors, we found that providers were 88% more likely to screen their own Black patients than their white patients with the same risk profile. So even going into the pandemic, we knew that implicit bias and equity was a major area to start. So we're kind of walking into this global pandemic, already screening less than we should be and screening in an inequitable way. Next slide. So let's talk about the bad. I mean, how much worse can it get? It got a little worse. So what happened to STI care delivery during COVID? And you can, Harper, just kind of click through these. So we lost in-person visits, and this is important when we talk about school-based health, because we didn't just lose in-person visits in the clinic. In Philadelphia, where I practice, our schools were shut down for the entire academic year, remaining year of 2020, and then through the following year. So we had no school doors open for 15 months, which meant we lost our chlamydia screening program within the school. There were limited testing opportunities as within primary care. We were only preserving those visits for acute concerns. Even adolescent well visits went away because there was a need to get the babies in and get them vaccinated. So we really stopped doing routine preventative care for several months. As we weren't testing, we weren't treating. And when we weren't treating, we know that the amount of time that someone is able to forward transmit an STI is longer. So we had a higher sort of circulating pool of young people in the community who didn't know that they had an STI and thus could transmit it to partners. Early on, I remember people saying like, well, they're on lockdown, who's really having sex? Haha, I will tell you, so many people were having sex because when we saw people on telehealth, many adolescents were telling us that their relationships hadn't changed. They were still having sex, but they had decreased access to condoms because they weren't able to come into clinic for pickup or to get into the pharmacy for pickup. We also saw significant divergence of our public health infrastructure, like partner services, away from STIs and to COVID-19. And then lastly, just when we were sort of getting back to speed, we had a supply chain breakdown where our Aptima test kits, really what we were able to use to test for gonorrhea and chlamydia, those supplies were diverted to COVID-19 testing supplies, and we had a national shortage and had to go into supply preservation mode. Next slide. So what did this look like in terms of our data? A little bit of a busy graph, but along our x-axis here is time from 2019 to 2020. The left y-axis is how many chlamydia tests we sent in our 31 clinics, and our right is our test positivity rate. And you can see until about February 2020, we're trucking along, sending about 1,000 tests per year and having about 10% of them being positive. But we saw a massive drop off in March of 2021, where you see our test volume goes down, and our test positivity goes quite high. And just when we had recovered, we got hit with our supply chain stock out. And again, we halved the number of tests we were able to send out. And because of that, our test positivity went up again to almost 20%. Next slide. So what does this mean? This means we really actually massively disrupted doing asymptomatic testing, which is what our school-based health program had done and what primary care had been trying to do. So here we see time marching along to our 2020 pandemic period. And on our y-axis is the percent of our STI tests that were sent that we classified as being asymptomatic, so a patient who had no symptoms. And you can see that those routine screens went from being about close to 75% of the volume of tests that we were sending, way down to about 62%. So this translated to, we're missing about 10 to 15% of expected STI cases, which is several hundred STI cases that were missed during the pandemic when asymptomatic screening went away. Next slide. Now, I've painted a little bit of a bleak picture, but now I'm going to start getting into the good news, which is going to show how was our health system resilient during these challenges. So another poll question, for those of you who are doing telehealth, how much of your practice in general for delivering any STI services is by telehealth? Less than 25 to 50%, or more than 50%? And as you answer that question, Harper, you can go ahead and click on. So we went from a health system in the first 30 days of the pandemic that had zero telehealth. We were doing no adolescent visits by telehealth pre-pandemic, to scaling up 400 visits for teens within 30 days. So we had a very rapid scale up. Now, this isn't just STI care. This was sort of all cause adolescent care. So thinking about menstrual disorders, contraception, eating disorders. But it was proof of concept that when a health system puts their weight into rapid innovation, it's doable in a way we had never dreamed. And it looks like, I'm looking at our poll results, we have about half of people are doing no STI care through telehealth. About 25% of their STI care is telehealth, and about 8% are doing 25 to 50%. No one's doing more than half by telehealth. And I think that's pretty normal because there's some challenges to doing STI care delivery through this modality. So speaking of which, we ended up, in addition to our routine adolescent healthcare services, we have 2 Title X funded clinics. Those are able to provide free and confidential family planning services. And we decided that it would be critical to be able to scale up those services as well. So we started an all video-based family planning program, which definitely has challenges. We want to get people free medication. How do we get it to them? So a lot of figuring out, doing a video visit, and then having people do a curbside drive-by to pick up the meds, mailing meds to the home. With STI screening, there's always this question of how do you get the sample collected? And we'll talk about that in a minute. But we also found that it really opened up our scope of practice in other ways. I'm in Pennsylvania. We're a state that is permissible for expedited partner therapy. That means we can give meds to the partner of a patient who has an STI, or send that patient out with meds to give to their partner. But we have no legal immunity in that situation. We are not an EPT allowed state. And because I'm part of a health system that treats minors, our hospital has never been super enthusiastic about us doing EPT. Telehealth allowed us to have conversations with our patients and say, hey, Does that happen to be your partner sitting next to you? Can we get him on video and really rapidly register the partner for a visit, do a video visit, and do EPT and see the partner, thereby, doing a sort of modified, not exactly expedited partner treatment, but what we called express partner treatment. And 85% of the teens that we reached during this program found it very highly acceptable, with the other 15% still finding it acceptable, but stating that they would still prefer to be able to be seen in person. Next slide. So how did we manage confidentiality during telehealth? Because this is a real challenge. So we use a mobile app as our patient portal. And the way that ours works is that after a patient turns, that should say 13, after the 13th birthday, their parents no longer have access to the app. They need to set up a proxy account to have any access through that electronic health record account. To the proxy account, you cannot release any STI-related, HIV-related, or contraceptive-related information, so that that information stays closed and private. As many health systems have been challenged with the 21st Century Cures Act and thinking about how do we again protect the privacy of the adolescent health record, we were able to put additional privacy protections in place that prevented any automatic release of confidential labs or medications. So no antibiotics, no STI or HIV information could be released automatically through 21st Century Cures Act. Next slide. Now, I don't want to paint telehealth and these innovations as being the golden goose. There have been challenges along the way. And one of the biggest ones we've seen is equity. We've seen in our health system and really nationally across ages and across health conditions, lower rates of utilization in Black, Indigenous, Latinx, and other people of color, and in rural individuals as well. It's important because I think a lot early on people were saying it's devices, we just have to get everybody devices. It's really not devices. When we've done survey work, even amongst homeless teens, most people have device, but what people don't have access often to is high speed, high quality broadband internet that allows multiple people in a household to be able to get signal at the same time, and privacy, having a private protected space in which to have sexual health conversations. We also have challenges with lab collection through telehealth. So while if you have a completely asymptomatic patient who has an STI exposure, it's quite straightforward to send the antibiotics through. But if you have a symptomatic patient where you're concerned about the possibility of pelvic inflammatory disease, you want to make sure that you get an exam. And also for a patient where you're not sure what organism you're treating, you want to get a specimen, there's still limitations to telehealth in those contexts as well. Next slide. But let's talk about the better. And this is my favorite part, because this is thinking about how COVID, aside from just telehealth, has been a massive innovation lab for STI care for adolescents. So poll question 2, just reaching out to see if anyone's doing any sort of innovative practice in STI testing for gonorrhea and chlamydia. If anyone's utilizing point of care testing, home collected testing, both or neither. And as we get that poll data, we can go ahead and click through to the next slide. So when we think through acceleration of innovation, there's a few different modes of that with respect to STI testing that have really come along during the pandemic. So the first is the idea of self-testing models. The sort of proof of concept for this is HIV home tests or self-tests, which are now available in most pharmacies or can be ordered via mail. The Philadelphia Department of Public Health actually created a great campaign where you could go online and order a self-test kit to be delivered to your home to get around the issue of many sites being closed testing. However, for self-testing, we're really still mostly in the world of HIV. We don't have good, ready-to-market gonorrhea and chlamydia self-tests that are available yet. So what many programs that were doing telehealth during the pandemic did was use a home testing model, where basically in advance of or on the day of the telehealth visit, the patient would be mailed a gonorrhea and chlamydia test kit. They would swab at home or collect a urine sample at home, depending what type of test kit you were doing, mail or drop that off at the clinic so that you have the telehealth visit, you have the home collected specimen, that specimen gets routed to the lab, and then you can see that gets routed back up to the clinic to have a second telehealth visit for result disclosure and treatment. And that model was increasingly brought to light in the pandemic as something that can be acceptable and feasible to patients. So I'm looking at our poll results, and it's awesome because it looks like 44% of people are doing point of care testing, 22% are doing home collected specimen, 6% are doing both, and I would love to talk to you 6% to hear about how that's going for you, and 28% are doing neither. And we can skip on to the next slide. Now, just recently, we have even a newer path, which is point of care rapid molecular diagnostics for gonorrhea, chlamydia, and in some cases, trichomonas. So during the pandemic, we've had FDA approval for CLIA waiver for 2 devices, which can deliver STI results within 30 minutes. On the left is the Binks IO device. This does gonorrhea and chlamydia for males and females, urine from males, vaginal swabs for females, and I believe has a minimum age threshold of 16 on its CLIA waiver, but allows for conceiving of really a drive-by testing model where you can have your telehealth visit, really just go into the bathroom, give a sample, have a nurse or MA run that sample, get back on your phone, and have delivery of treatment all in the same 30 to 45 minute wraparound time frame. On the right is the Visby device, which is actually a handheld single-use disposable device that tests for gonorrhea, chlamydia, and trich in vaginal swabs only. This also has a 30-minute rapid turnaround time, really, again, potentially opening up opportunities for merging these devices with telehealth and other innovative care delivery strategies. Next slide. We also have the opportunity to think about creating spaces. Again, this idea that it's not just broadband, it's not just having a phone, but it's having these spaces for equity. So school-based telemedicine is obviously an excellent opportunity for that. Is there a way for people to either use their own devices, or if devices are hard to get, using a kiosk-based model? So on the left, this is not a school-based center, but this is the VA Soldier On model where they did community location of kiosks for telehealth. So even if someone didn't have a device, a veteran or another person in the community could go to CVS, could go to the Department of Health and Human Services local site and actually get onto telehealth there in a non-traditional healthcare space. There's also more and more for-profit companies like HealthCube that are getting into the space and are trying to kind of create a room within a room space where a health kiosk could be created actually as a 3-dimensional space within a community as well. And as we think about creating those spaces, we also have to think about this issue of broadband as a public utility and continue to advocate for access there. Next slide. We've also been experimenting going beyond broadband, and just in this last year have developed a mobile clinic. This is designed by teens. You can see the cool artwork. Our youth advisory board actually had our youth advisors choose the artist, choose the artwork, and they choose the community programming for where our unit is going. In the next year, we have, this is basically an RV. It's got 2 bathrooms on it and a mini lab space, but we're going to be rolling out point of care testing here. So actually where there's not a clinic, bringing the clinic to our adolescents. Next slide. And then the last thing, and then I know I'm running short on time, so I will make this quick, is that as we've gotten more people on our patient portal app, we've had more opportunities to support universal screening. So before the pandemic, no one was on the patient portal. Now everybody is. So we created an adolescent welcome letter that creates a standard of expectations for what's going to happen when a teen comes in for a visit. That there's going to be blood and urine collected because that's in accordance with the best standards for STI testing, for AAP, and for CDC. We were able to, in a single push through, reach 40,000 families and teens through our patient portal in January, kind of dropping this you're gonna get screened, text to them, to create that positive expectation around universal screening. And now every Tuesday, the letter is sent through the app to each patient who turned 13 during the prior week. It also goes to their adult proxy so that the expectation is on the level of the patient and on their proxy. And I think my next slide is just the last of the innovation slides. Also, by getting really this sort of norming around electronic tools during the pandemic, we created an electronic self-screening tool that all our teens fill out at the beginning of the visit that allows us to get sexual activity information before the doctor even walks in the room. Teens are able to do this on their own phone or iPad. We had a BYOD campaign, so they could do it on their own devices. And really, we now know before we walk in the room who might need screening, who might need PrEP, who might need emergency contraception. And my hope is that this reduces some of that biased decision-making about who is getting evidence-based sexual health services by allowing us to build in nudges in our EHR so that those decisions are standardized. Next slide. So this is my last slide next. This is just our future priorities. We need to think about ways to rapidly validate within labs these procedures for alternate testing strategies. We need to figure out how to get reimbursed for doing all of these innovations, because right now the path to that isn't clear. For telehealth, there's a huge need for cross-state licensure, as our state licensure waivers typically went away after COVID. We need to think about sustainability of these programs for the long run, and a focus on designing for equity and having youth at the table. We got 400 telehealth visits done in 30 days, but we got no youth input in what our platform looked like or how it was going to roll out, because everything had to be done fast, fast, fast. It's time to breathe and get our young people back to the table. And that is it for me. I'm happy to take any questions at whatever point in the webinar it makes sense to do that.
Thanks, Dr. Wood. We're going to hold some questions towards the end to make sure we have time for everyone.
Right. Thanks so much.
Great. Thank you so much, Dr. Wood. I am now going to introduce you to Dr. Patricia Wells, or Pat, a Detroit native and lifelong Michigander. She had some brief stints early in her career in Palau, working in marine fisheries, and then in Minnesota in the 80s, working in HIV epidemiology. Her love of working with adolescents and STIs started during medical school at Wayne State University, where she coordinated a program of medical students to graphically teach Detroit public school students everything their teachers never told them about HIV and STIs. Dually trained in internal medicine and pediatrics, she came to the Corner Health Center in Ypsilanti, Michigan, after careers in private practice and pediatric emergency care. And as a parent, she never tires of telling her own children everything they never wanted to hear about STIs. So welcome, Pat. It looks like you're muted.
Thank you so much. So I could have listened to Dr. Wood all day, and hopefully we'll get some more time to hear some more from you. I think I was invited here today because, unlike a lot of the other speakers you'll hear, we are not at a funded major university, and adapting telehealth program like that can be really daunting for those of us who are in smaller health centers. You can just keep going. Keep going, thanks. One back, sorry. So the Corner Health Center, keep going, sorry. Maybe I should spin, was founded in 1981 in response specifically to disparities in teen pregnancy rates in the zip codes near us in 48197 and 48198. We are just outside of Ann Arbor. We're in Ypsilanti, Michigan. And the healthcare for our folks in Ypsilanti left a lot to be desired, with very high teen pregnancy rates and minimal access to care for those kids. Keep going. So the Corner Health Center was started literally in the corner of Ypsilanti High School to address contraception and pre-pregnancy care for our kids. In the late 1980s, the state of Michigan prohibited the prescription of or distribution of contraception in the public schools. And so a capital campaign was held for a lot of very interested parties. And we moved into our building where we have been for the last 31 years. So the Corner Health Center, we are in our 41st year now. We were the state's first school-based health center of its sort, and we are now a school-affiliated health center. Keep going. So we do continue to get funding through the state, and about a third of our funds come through patient care, about a third through grants and donation, a third through grants and a third through donations. And our mission is we serve patients who are 12 through 25 and their children age out when they do at age 26. We are not a free clinic. We take most insurances, and we have a very generous sliding scale for those who don't have care. It's fun. Starting from a one room in the corner of a school building through the past 40 years, this is what we have built into. We do all of these services here. Our primary mission, of course, is still reproductive health care. We provide full-based medical care and have expanded to, we have a robust behavioral health program and counseling. We have in-house psychiatry, HIV services. We have OB and midwives. We have doulas. We have everything that you see here. And we actually have a food bank and free store as well, which used to be incentive-based. And during, as people got their, they earned points, actually, when they got their care toward programs in the store. And now during COVID, we just made that a free store. Please go on. Because we are a school-based health, a school-affiliated health center in Michigan, I always do that caveat, we do not refer to or perform termination services. Next slide. In Corner, I don't have, we have, last year we had, I think about 1,600 individual patients with close to 6,000 total visits. The majority of our patients right now are over 17, with about 15% the children of our patients. 90% live at or below the federal poverty level, and the vast majority of our patients also live in our local zip codes, which was our founding mission. Go ahead. So in 2020, early in 2020, we really started seeing who was dying in other states from COVID, and that was predominantly people, not only the people who are in senior living communities or who were senior citizens, but also people who live in crowded situations, multiple people to an apartment, people who were Black or other indigenous, other people of color, people with chronic illnesses. And so this was really our, I'm just getting a correction from one of our folks. We had 9,000 visits last year. People who are much more likely to die of COVID. So we needed to protect not only our staff, but our community. And we needed to mobilize pretty quickly. Go ahead. So pre-pandemic, our waiting room was a very busy place filled with very social. So a lot of education happening. We had after school programming. We had early parenting programs and centering pregnancy programs right on site that we had to quickly decide what was going to happen to keep our patients and staff safe. Go ahead and move on. It's our waiting room. Is there a poll that goes here now? Oh, here we go. So this poll, how successful were you in utilizing telehealth and continuing providing quality care during the pandemic? This was, this was a wild time. Many of us were shutting down. We were watching people shut down, right? So while we're filling this out, I'll go ahead and say that I had long wanted to utilize telehealth as an equity issue. We're very much like a rural health center in that our patients often can't get to clinic, have transportation needs. Am I supposed to be reading this poll?
Looks like we had about 54% who did not provide any telehealth services, 15 said they were not very successful, and 31 who said that they were very successful. But we, of course, commend any program that made that quick transition to telehealth and
No,
continue
and
care.
And if there's any point I'd like to make today is that you can do this. As a small health center, you really can do it. And let's show how we did that. So next slide. Again, we knew that we needed to keep everybody safe. So what we did was, and I'm not sure, you know, as also an emergency medicine provider, I'm not sure that we're not going to have some needs to limit in-person care again. So we created teams, actually a front desk person, an MA, a nurse, and a provider, one set at home each day and one set in the office. So that was limiting. We actually created little mini pods, and so that we kept them exposed only to each other and kept them safer at home. We created in February, we had universal masking, we put in HEPA filters. And one thing it's nice to be in a small ship that can turn easily. So the nurse practitioners and I literally sat down on the floor one day in February and decided what would have to be in person, and so that everybody else could be tele if we could shoot that button. So we decided early on that contraception and emergency contraception should be on site. STI evaluations on site. We did change that over time. Specific pregnancy visits, and we got everybody home blood pressure cuffs to be able to have those televisits while they were pregnant. And we wanted well child visits, especially with the immunizations here in the office. And we had our MAs on site able to do shots, labs, immunizations. We can go ahead with that. This is interesting. I found this the other day in February of 2020, my press for telehealth, which I had been hoping for a long time. Keep going. But you know, the big problem was source, right? So how do we choose a platform? And those are things you have to look at specifically for your office. I think you have to, yep. So we reviewed a lot of options, and my basic requirements were, obviously I wanted HIPAA compliance, even though the laws were relaxed, and through a bunch of 2020, people were even using FaceTime. The sensitive nature of our practice with the people, we have, you know, formerly trafficked patients, current trafficked patients, I needed the HIPAA compliance to know that we're assuring our patients of our privacy. We really wanted within the platform itself, so within the visit, to be able to message or text our patients. And predominantly that was to be able to make sure that they're secure. If there was something private they needed to say to us, I wanted to be able to text the patient and them to text me to make sure that nobody else was in the room and that they felt secure saying what they were saying. I liked the ability to convert to sound only. Many of our folks didn't have broadband, and so we wanted to be able to convert immediately into sound only if we needed to make it a call. And this was important for us. I needed to be able to, within the platform, decrease the image quality, because again, a lot of our patients didn't have a lot of data. They had multiple family members at home who were using the same router, and so we needed to be able to decrease image quality so we could still see those patients. And we like the ability to either invite by text or email. A lot of programs are text only invites or through a portal. A lot of our patients don't have portals, and so it's nice to be able to text directly to their device or email. Whichever they have, we want to be able to meet them where they are. Of course, affordability for us, we're a small center, we needed to be able to afford it. And it had to be user friendly because we had a lot of people adapting quickly. So I have no background with Doxy.me. This is what we ended up using. Doxy.me does have a free option, which is very nice for those for those clinics who don't have funding to be able to hop onto telehealth. The optimization, the personalization is all with the paid model, which we were able to do with some donations and some, and knowing that we were going to lose the funding, we were going to lose the visits if we didn't jump onto telehealth. You can see here there is the ability to text patients. You can invite them by email, and on the side you can edit the waiting room. You can change the account, what everything looks like and what the patient sees, and they are able to do a pre-call test to make sure that their data works. So we do ask our patients to do that pre-call test before we hop on, Keep going. Really, it doesn't take a lot to get going with telehealth. A private space. It's nice to have the laptops. It's nice to have the HD. You don't need special cameras. It's nice to have the laptops with the HD cameras just because our teens are very savvy. There are a lot of wonderful social media sites that they are curating now. And so it's nice to have a nice camera and lighting. I find it helpful to have a second screen available so that I can chart during the visit. It makes it very easy to chart during the visit. I like a headphone with microphone. Some of my staff just use their computer. Lighting is important. Again, these kids are used to curated sites and they need to be able to see us and know what we're talking about. Putting your laptop on the stand helps, phone, and of course, all important, having pants available. Everybody was home. Keep going. This was early on. We just slapped it together, put two computers in a room, put a special room, and we had our telehealth going. We went, about half of our office space was utilizing telehealth within a week of heading out. We now mostly use one laptop. Keep going. By the end of 2 weeks, we had converted 70% of our visits to telehealth in March of 2020. The nice thing about many of the telehealth platforms is they do have a way to do analytics. So I just pulled up the analytics from our last year, and you can see that you can pull up the number of visits. This is also very helpful for coding for time. So you can actually see the exact number of minutes that you were on your call to be able to code. So we can see total since beginning of utilization, we've used 104,000 minutes of time. We've had about 6,000 total sessions. On the back, interestingly, you can see on the bottom side, the most sessions we've ever had in a month were in April of 2020 at almost 500 sessions. And also interesting, which I didn't realize, last month we did our most minutes in a month at 7,000 minutes last month of telehealth. So our social workers, behavioral health providers are almost still completely on tele, and probably now we're at about 20 to 30% of our visits are tele. Keep going. Yep. So, and then we've often talked about value in upgrading platform. If you started early on a very basic platform, is there value in upgrading? So there's been a lot of work in the last 2 years on EMR integration. Epic has its own integrated EMR. I know people of Epic who have chosen to go for secure Zoom instead. The EMR integration is very nice. It is easier, obviously, for the provider to queue up directly from within the chart, but at the same time, a lot of patients have elected not to have portal, especially teenagers don't have portal in many situations. And so, and that's where those appointments are housed, so it can be more difficult. And using it from within your portal can add bandwidth. There is value in training the staff to register, triage, and queue patients from right within your EMR, which is highly valuable. And upgrading platform, or just even upgrades across what we're about to start doing, is really upgrading to much more standardized devices across our practice, making our lighting consistent and our backgrounds all consistent, so that we all are sending out the same message. Keep going. And I'm not sure, I think maybe it's on another slide. We created a system where patients could have their telehealth visit and then come in for shots, do it, as Dr. Wood was saying, a drive-by visit for shots or testing. Keep going. So one thing that we loved is having that real-time communication between the staff, so that so we use Athena. So right in Athena text, our staff is constantly communicating all day long to pick up a call, to go and see where someone is, to create a social work visit, get somebody food. So we were doing food deliveries throughout 2020 because the schools were closed and people needed school lunches. Lighting is important. These kids, again, they have curated sites. Lighting is important for trust. Camera position. I've been on Zoom calls where I see people just with the eyes, and patients need to see our whole selves. We love, we've talked about this before, having a secure space so that we can actually turn the camera around and show that our patients that they have privacy. Having nobody walk around behind us is very important, except of course for your cat. Setting the expectation that the exam will not be showing body parts of the body that aren't covered by a bathing suit, that are covered by a bathing suit. I don't want somebody doing a sensitive exam on telehealth for obvious reasons, especially because we see minors. Registration, it's very nice if in your EMR with the registration, whoever does your appointments puts a backup contact so that the provider isn't left thinking that someone has no-showed them when in fact that person is not able to get to their phone but has their email up. Prompt opening of the visit is also always very important because, especially with adolescents, if you're not there in a few minutes, they bail and they're gone. One thing that we found that was really helpful for us is we did create a whole new appointment type in our schedule. And these were called like telehealth MA visits or telehealth nurse visits. And what these were for those drive-bys so that we could send patients in. So during their telehealth visit, we'd identify they need a specific immunization test or visit, and we could create a visit specifically for that on the schedule. And patients loved it. They could come in on their own time and leave a sample. So of course, the benefits of telemedicine, you guys all know that removal of barriers is huge. The average in-person medical visit in this country takes the patient 2 to 3 hours between travel, waiting room visit, and all the transition times of getting back to work once you're back in the office. Patients, it's been wonderful having patients be able to take their appointments from work and returning right back to their job with minimal disruption. We have decreased our no-show rate significantly with telehealth. Obviously, those difficulty with ambulating, they're able to take the visits directly from the comfort of their home or their bed. And our patients have a lot of difficulty with transportation. So the ability for them to do a televisit when they can't get a ride here or a cab or an Uber or the buses aren't running has been huge. And of course, being able to stay home with your kids because your kids are home for school or your family members, being able to stay home and babysit while and do your televisit at the same time has been huge. I find, just to add in here, I'm not sure if it's on the next slide, but especially the teenagers are so used to communicating through social media and through screens that they tell us a lot more than they do in the office. They're much less inhibited. And here it is, the joy of interaction. That's huge. Again, they're much less inhibited. They love seeing us. They love seeing our spaces, and we love seeing their whole faces that aren't masked. We're always happy to see them, and we get to see their space. And there's a lot of gratitude to be able to see each other and have a patient call in and be able to just pop right on. And instead of having a nurse try to triage a visit, we can pop right in, capture that visit in real time. Of course, the personalization, we've already talked about that, so we'll keep going there. That insight into our patients' lives, and of course, hearing the families. So seeing their spaces, understanding the chaos that kid lives in, or that they're failing in school because they've got 3 people climbing all over them or utilizing their bandwidth. They love showing us their room, their pets, their spaces. Especially young college students and high school students love that piece. And it has been really a gift to be able to, because we are going to remain an all mask facility. So it's really been a hugely comforting to be able to see our patients. I have patients who just had televisits this week. I haven't seen their faces for 2 years. It was so exciting to be able to see their faces and how they've grown. And while our patients are coming on time, this is coming online, it's very nice to be able to just finish that last chart while we're going. While sitting at the same desk without having to go back and forth to a patient room. It does save a lot of time. And this face-to-face results reporting put there, it is very nice for for us to be able to call patients with their positive STI results rather than having to do that over the phone or finding out through a portal. And arranging follow-up visits is huge. We've had obviously I'm sure a lot of you being closed over the last, that first year had a lot of ER visits and urgent care visits, and we can schedule those follow-up visits quite easily with telemedicine without patients having to come in sick. I think I'm pushing the time. So somebody wave me off when you need to stop. And of course, the safety. So we were able to keep our staff and community safe with all these instituted policies that we had, and we had very rapid adoption of vaccination when it was available. Our first staff in our entire building, we never closed a corner. Our first staff case of COVID was just before 2022 started. So we kept our, it's true that we kept our staff very safe. And to date, we've had 0 in-house transmission. This is just one of those personalizations. So this is one of the anecdotes. We have our nurse practitioners had a whole lot of anecdotes to share with you about telemedicine and sexual health, but this was a patient who had just gotten out of the hospital and had a follow-up visit and clearly was much better on her way into Starbucks. And just while we're doing that also, we have, for testing, we have fully adopted self-swabs. We don't have on-site rapid tests. We have patients doing self-swabs and urine. We've been doing that for years. So that's been very easy for us. And we did, Jennifer, we did institute the youth engagement early. So we have a youth advisory council who was able to, they loved practicing various platforms with us early on and helped us choose which platform was the easiest. And they actually were the ones who advised that in-app texting. And we did evaluate, we also brought in, we made protection packs. So you were saying that they didn't have access to the condoms. So we actually had little brown bags with, we always have brown bags of condoms. We had brown bags of condoms and masks, and there was your protection vest. Pack it out the door. Super fun.
Wonderful. I love the combo protection pack. It's very cute.
I love those. The kids love them.
Right? What a great way to kind of package those all together. Do you have some time for some questions and some that came in? Dr. Wood, first, can you give us a bit of an overview of this school-based health program at CHOP?
Yeah, so that's a great question, and I'll answer by saying we don't have a specific school-based health program so much as the Philadelphia School District has school-based health centers in some of the schools, and they provide varying levels of care. It's often at the principal's discretion, so there's not a standardized formula. So for instance, we work, I think, within at this point 5 school-based health centers. Some of them, it's really just having the health educator present. Some we're doing pregnancy testing and gonorrhea and chlamydia testing. But what's been standard across the district schools is having a chlamydia screening program that's really run by the Philadelphia Department of Public Health, where once or twice a year, every kid is given a urine cup and a brown paper bag and sent to the bathroom. They bring the bag out with the cup in the bag so that they can sort of opt in or they can bring back an empty cup or a full cup without having to disclose anything about their health status. And that's actually been really our safety net for universal screening in the city. So when COVID happened and the schools were closed, that was a huge loss to us.
Thanks. I feel like this kind of connects to that, but can either one of you speak to thoughts on how local health departments can support providers to implement universal screening? Oh, Dr. Wells, you're muted.
So interestingly, with the shift in Planned Parenthood funding, each state had to figure out what to do with their Title 10 money. Michigan had decided to distribute it through the county health departments in late 2019. Unfortunately, 2020 hit, and so many health departments did not have the ability to create those Title 10 clinics. So getting those Title 10 funds distributed and getting access through Title 10 would be fabulous.
Yeah, I would say also getting messaging from our state and local health departments that we should be universal screening would be really helpful, because in general, while we have our CDC guidance that talks about screening in sexually active females and that now evidence is sufficient to support chlamydia screening in males, it doesn't come quite down and saying, it's now saying that universal screening is acceptable. But for us to really remake the loss that we've had in screening from our the pandemic, and knowing that there's significant racial and socioeconomic bias in who gets screened, I think that there needs to be stronger language from health departments really supporting in adolescents, given the rising STI rates, that there is a need to universally screen, because that sets a minimum standard for private health systems, academic health systems to then follow.
Thank you. Dr. Wood, will there be a kickoff event for your mobile clinic? And do you have a summer schedule of where it would be? It sounds like that's a question for someone local.
Yes, hi, Iva. I know the local person. So we don't yet. You know, what's interesting is we got the funding for this school-based clinic right as the pandemic hit. And so we had all these grand plans for going out in the community. We actually got commandeered as a COVID testing unit and a vaccine delivery unit for about a year and a half. So we just got our mobile unit back. Obviously a really good use of that resource, right? But this is another example of how, you know, priorities that we had pre-pandemic really had to shift into this crisis response mode. And now we have to kind of flip back to being able to deliver services as intended. So stay tuned, we will have more information soon.
That's great. I love that we're building that connection there with all of you. Okay, one last question. Dr. Wood, I'm guessing you're best positioned to answer this, but Dr. Wells, feel free to hop in if you know. Is there data that breaks down what portion of positive STI rates are unique versus repeated individuals? Could an increase in regular STI screenings as part of care for things like HIV and PrEP be a factor in the increase?
Yeah, I will say in my side job as an epidemiologist, it's a great question. We are screening more in the setting of PrEP, but we have to remember when we think about adolescents, adolescents represent about 2% of HIV pre-exposure prophylaxis users. And since so many of the new STIs that we're finding are in adolescents, and since we're actually screening adolescents well below target, I don't think we can attribute those to just increased screening alone. I think it is truly new cases that we're finding. I manage a data cohort of all the STI screening within our network, and what we found is about 33% of adolescents do have recurrent infection, and about half of those infections happen within a year. So we are definitely seeing repeat infections. These are not all unique individuals, but I do think that there's enough data to say that when we look at the teen population, that is really true all-cause increase in infection incidence. But I'd love to hear, Dr. Wells, your thoughts on that as well.
As well, yes, please.
I wish I had the numbers in front of me, but definitely we're having a rise in new infections and not just repeats. And I think part of it is screening, and completely agree with the messaging for screening. And it has to go to parents. It has to go directly to parents, that they need to expect that their 13, 14, 15, 16-year-olds are going to get screened. Our biggest issue is parents not wanting to pay for it. So that needs to, that's where those Title X funds could come in very handy.
Great, wonderful. Well, thank you both for your time and for sharing with us today. We are honored to have had you join us. And for anyone in the audience, please feel free to reach out to two presenters here today with any questions. And please, if this is a topic that you're interested in, be on the lookout for a toolkit launching soon from NCSD about this topic. Thank you all for joining us today.